Hi all, Namaste. This is Dr. Jishnu Narayanan and welcome to the Institute of Drona. In this series, we will be talking about eczema, different conditions which we can include under eczema, and briefly about the Ayurvedic aspect of the diagnosis, clinical assessment, and management of eczema in clinics. So let's start and see how we can manage the eczema in our clinical life. The term eczema is synonymously used with dermatitis, inflammatory dermatosis, and just means the same, that there is a pathological skin condition where inflammation is the background pathology happening. And it's a broad umbrella term where many conditions like the most common chronic condition of atopic dermatitis to a condition of acute stated like contact or allergic dermatitis is included. So all these conditions can come under the term eczema. And in this presentation, we will be taking it in two parts. The primary part will be dealing mostly with the clinical presentation of the disease and an easy and practical approach of Ayurvedic assessment so that it gives a base for planning the further treatment. And in the second part, we'll be dealing mostly with the treatment principles, then treating the acute and chronic conditions, and few of the most common effective medications mostly used in the southern part of India. Atopic dermatitis, it's a chronic condition. So mostly more than 90% of the condition happens even before 5 years of an age, or even 50% of that happens even before 1 year of the age, and it stays along. It stays along at least till the adolescent period, and few of the condition, like maybe more than 20-25% of the condition, even stays with the patient in his or her adulthood. So it's a very chronic condition, relapsing in nature. There will be phases of remission, there will be coming back, and itching is the most common difficult symptom which is presented in this condition. And usually it happens over the skin folds, maybe over the neck areas, over the popliteal fossa, thin thigh folds. These are the usual areas of atopic dermatitis, and there is a strong association of history of allergy, whether a personal or family history of allergy will be there. So just to summarize, atopic dermatitis is a chronic relapsing pruritic inflammatory dermatosis with periodic erythematous lesions over the skin folds associated with personal or family history of allergy. So usually it's an itch that rashes, like the itching will be the primary symptom the patient will be presenting with, or the bystander will be telling us, and the rashes comes after that. So it's an itch that rashes. Atopic dermatitis, the atopy just means that there is an inherited tendency in that patient to produce IgE antibodies in response to maybe a very mild entry of any triggers like proteins or pollen or stuff like that. So usually it comes up as a triad, as a group of 3 symptoms like asthma, atopic dermatitis, or allergic rhinitis. So there will be rhinitis, there will be breathing issues, and along with that, dermatitis is there. So this triad is being seen in the clinics, and most commonly the diagnosis will be towards the atopic dermatitis. And usually it also includes many symptoms like migraine, various food allergies or allergic urticaria, drug reactions. All these can coexist in the same patient, and it gives the physician a clue that it can be a diagnosis of atopic dermatitis. Mostly the pathology is being divided into two. The one is a defective skin barrier, and the second one is an imbalance of the adaptive immune system. So there is an issue in immune system which makes the condition of atopy. So there will be, for simple triggers, there will be a huge response from the system. So that is one part. The second part is there is a defective skin barrier. So that is also concerned with the mutation of few genes like filaggrin, where the skin barrier is being getting too much of dryness. The skin will be getting too dry. There will be porous opening over the skin so that the external atmosphere and external environment can interfere into the system more easily, and there will be entry of pathogens or entry of triggers very easily into the system. Along with that, there will be a loss of water from within the system. So there will be increased loss of water, which is giving hydration to the skin, which is giving the lubrication to the skin, that will be lost due to this defective skin barrier. That is one thing. Along with that, there will be an entry of the minute triggering factors from the environment, which gives the trigger to the immune system, and there will be a production of symptoms. So it's a complex phenomena happening in the background, attributed mainly to pathologies. So as we have told that there is an involvement of a gene, usually these person will be attributed with or coming with few peculiar symptoms like cirrhosis, severe dryness of the skin, there will be dermographism, hives, then urticarias, very dry, fragile hair, Danny Morgan fold or the twin folds that is happening below the eye, then post-inflammatory hyperpigmentation there, the cheeks or the below the eyes, there we can usually visualize the blackishness or hyperpigmentation. So all these type of condition can coexist in the same patient because of the mutation in the same gene, and it can give the clue to a physician that this is a condition of atopic dermatitis. Usually, diagnosis of the condition is clinical. So pruritus is a mandatory symptom. If there is no pruritus, then we cannot diagnose it as atopic dermatitis. Along with pruritus as a mandatory condition, any of three conditions from these five symptoms, if it is satisfying, then we can actually diagnose it as atopic dermatitis. Either the patient should be having asthma, or the origin of the condition should be before 2 years. The skin will be generally dry, either involvement of flexural area when the patient is coming into the OPD, or there will be a history of flexural involvement. There will be, so these five conditions, if at all any three are satisfying along with pruritus, usually we can diagnose it as atopic dermatitis. And majorly we classify them, even though may not be very important for the treatment aspect, but still we classify them under two headings. One is extrinsic or allergic atopic dermatitis and intrinsic or non-allergic AD. So extrinsic or allergic AD is the thing what we have explained till now. All the factors of the atopic dermatitis will be satisfied in this condition. There will be those phenotypes, all the phenotypes will be available. It will be a severe condition of each. There will be IgE reactions happening. So specific IgEs can be visualized. So all these conditions will be satisfied in extrinsic or allergic atopic dermatitis. Whereas in intrinsic or non-allergic AD, they are a milder variety of the condition, and there will not be a phenotype changes perceived in that patient, and IgE related issues might not be visible. So, and it is a milder variety of the symptoms. So in that sense, it is being divided into two, basically, and clinically, depending on which age group is affected, depending on that, it can be again classified as three, like adulthood or pediatric atopic dermatitis, like that, which is not that relevant in current scenario. Again, coming to the triggers, so sun or irritants, food, and stress, season, all these are triggering factors, and we cannot attribute the trigger into only one factor. For example, season can be a very strong trigger, but we cannot firmly say that any specific season is the cause of or trigger of the atopic dermatitis. So it depends on patient, and it differs from patient to patient. So for few patients, it will be a specific season which gives the trigger, and for others, it will be some other season, but season will be or usually is a trigger for the system. And irritants or sun is a very specific and very potent irritating trigger to atopic dermatitis. Stress again is a very strong factor, and food, usually for childhood atopic dermatitis, food in their early period is a strong trigger, but as age progresses, as the person is more contacted to the allergen, usually that subsides, and researchers doesn't show food as a very strong cause or trigger in adulthood atopic dermatitis. So all these are few triggers which gives a very important or which is rather very important in planning the treatment and in understanding or making the patient understand how to live their life with atopic dermatitis.
Let me wind up the first session here, and in the coming sessions we will be dealing with all other diseases which we can include under the term eczema other than atopic dermatitis, and more than that we will see how well we can identify them and assess them through the Ayurvedic lens and through the Ayurvedic perspective. And in the last session we will be dealing about the management of all these conditions in Ayurveda. Thank you. Keep watching and keep supporting. Namaste.